Okay, so this is a patient that has reticular pseudodrusen, and basically, this is one of the few things that will cause progressive macular thinning and thinner than normal retinas. The other thing I think about in this situation is plaquenil toxicity or hydroxychloroquine toxicity. This is an older gentleman in his late 70s. And we've had the ability to follow this patient over 33 months. His vision's gradually declined from 20/30 to 20/40, and he complains significantly of night vision problems. So we can see his baseline vision 2023 was 20/30. When I followed him up in November of 2025, 20/40, and really a lot of difficulty with low light vision and driving at night. They just basically say, patients with this say they can't see or read anything. And you can see there's some peripheral drusen and reticular changes, a few macular drusen. Are typically very small and very uniform. Nerve looks healthy. I apologize that this isn't a more magnified view, but you can just see kind of a nondescript funduscopic appearance. Here's the fundus autofluorescence, and we can see some hypoautofluorescent dots and this kind of reticular pattern that follows in the macula and a little bit nasal to the nerve. And this is what's so interesting about this patient. You could see from 23 to 25, we've had progressive retinal thinning. And I think in 23, there was some suggestion of more thinning of the retina, that peripheral blue area that you see there, but definitely much more progression. And this was fairly significant. Over 2 years period. Here's the patient's fellow eye, and you can see on this macular change analysis, once again, progressive thinning. First thing we want to ask in a patient like this is are you on plaquenil or hydroxychloroquine? Here are a few things that can cause progressive macular or retinal thinning: AMD, inherited retinal dystrophies, drug toxicity, ischemia can actually cause retinal thinning, and then telangiectasia, like macular telangiectasia, and then a variety of inflammatory disorders. Why is this reticular pseudodrusen? Well, he's not on hydroxychloroquine. He's an older gentleman. He has these hypoautofluorescent dots. The thinning is in the superior and temporal areas first, and then that night vision issue that he complains about. Why is this important? Well, first of all, we want to rule out those other causes of retinal thinning, particularly hydroxychloroquine, which we can stop the drug and hopefully reduce the chances of the patient having further vision loss. But these patients develop a lot of geographic atrophy, and they're 2 to 6 times more likely to develop GA. They also have a lot of issues with night vision problems, and the reason that they do is because the reticular pseudodrusen sit between the RPE and the photoreceptors versus under the RPE, and it's thought that that does a lot more damage to the photoreceptors over time. Imaging, I found, is the best way to diagnose reticular pseudodrusen, and once again, that thinning on the OCT is really important. And these are the patients that might well benefit from photobiomodulation. My friend Marion Monk, who's in Switzerland, has said that these patients actually do see a benefit to their low luminance visual acuity when they have photobiomodulation applied. So reticular pseudodrusen are subretinal drusenoid deposits. The fundus autofluorescence can help you identify this, but I think the OCT is the best. You can see progressive macular thinning. This patient was a little bit more on the extreme side. And the night vision complaints should be a real red flag, as is the patient's complaint, kind of out of proportion with what you see on their OCT. And we really want to watch these patients for the development of geographic atrophy. And potentially talk to them about complement therapy if they start to develop GA. Thanks for watching.